Hello, dear colleagues. I'm glad to welcome you at the webinar, question-answer webinar, to the course Easy Endo in Primary Teeth. And first of all, I want to thank all of you for joining this course. And I hope that it was interesting for you and you got the information you were expecting to get. And today I'm here for you to answer some of your questions, which you got during your studying. And I would like to start with those questions which were sent by the participants who cannot be present here today live. And afterwards, I will ask you to write down some of your questions in the chat, and of course, we will discuss them as well. Okay, so we will go forward. And the first question which was sent to me before was if the bleeding in a root canal is dark after pulpotomy, should we wait for the hemorrhage control? Should we stop it first? So to answer this question, I want to go back to some of the slides which I presented in the presentations during the course and remind you that the signs of irreversible pulpitis are the dark blood, the color of the blood should be dark, and also the absence of the hemostasis after 5 minutes. In my opinion, if you know that from the anamnesis, the child had toothache in the evening, at night, and the pain was continuous, spontaneous, and when you open the pulp chamber, you see dark blood, it's not necessary to wait for hemostasis, because if we judge the complaints, if we consider the anamnesis, and if you see that the blood is dark, we can assume that this is irreversible pulpitis. Of course, if you're not sure, then you can wait for hemostasis and judge it again after hemostasis is achieved. Okay, so another question was like this. What should be done if we find only 2 root canals in a second upper primary molar with chronic pulpitis, and the third one is obliterated? Do we need to extract this tooth and put a space maintainer, or we can give it a chance? A patient is 6 years old. So I think in such cases there can be different scenarios actually. And I would like to show you some of my cases, which also had obliterated root canals. So this was a case of Paulina, who was 8 years old, and she came with the signs of irreversible pulpitis in her second primary lower molar. So she was complaining on continuous, spontaneous pain, and the pain started at night. And it was obvious actually that the pulpitis will be irreversible. If you look at the X-ray, you can see that the mesial root canal systems looks obliterated, right? And when I opened the pulp chamber and tried to find the orifices of the root canals, I realized that they were obliterated. And we discussed with the mother that actually, if we go for conservative treatment, there could be some complications. But the girl was very cooperative, and the mother was really willing to save this tooth. So we decided to give it a try. And I instrumented a distal root canal system. I filled this tooth with maisto paste, and we put some composite filling on the top. And as you can see, 12 months post-op, there is no periapical inflammation, and there was also no complaints. And I will show you another X-ray 2.5 years post-op. And you can see that here the roots are resorbing. It is a physiological resorption, not a pathological one. So we can consider this treatment being successful. So as you can see, I gave this tooth a try, and it was okay. Right? Sometimes what you can also do, if the patient is, as you asked, 6 years old, for example, and we know that soon there will be eruption of the first permanent molar, and we want to save the second primary molar, let's say, for a year, for example, right? Especially if there is also some pathological root resorption going on, not only obliteration of the root canals. So what we can do is we can also try to do the lesion sterilization tissue repair. And this is a technique which implies doing some pulpotomy procedure first. Then you have to enlarge the root canal orifices. After that, we take the etching gel, which we use for restorative work, and we etch the walls of the pulp chamber with the phosphoric acid. And after that, you rinse it and you put a mixture of some antibacterial pastes, which include the clindamycin, ciprofloxacin, and metronidazole. And you have to prepare them extempore together with, you have to mix it together with the polyethylene glycol and macrogol, which you can buy in the drugstores, and make some kind of a paste. So you take this paste, you put it in the enlarged orifices, and after that you put the glass ionomer filling and you cover this tooth with a stainless steel crown. Actually the indications for such technique, I want to remind you, is that it's the tooth which has some irreversible pulp inflammation, has some pathological root resorption, or maybe some obliteration also of the root canal system, and it should be not more than 1 year before normal exfoliation of this tooth. And we have to discuss this with the parents, because this is not the treatment which could last for several years, and the patients and the parents of the patient have to be aware of that. So if you have such a situation when you cannot go through one of the or two of the canals, you can either try a lesion sterilization tissue repair technique, or you can go for instrumentation and normal filling of one of the canals. Then you cover the pulp chamber with the filling material. You also put a good sealing restoration, and you observe this tooth in the post-op period. So these are two options. So in my practice, I would not go straight for extraction, especially if the patient was cooperative and the parents were willing to save this tooth. Another question was about the materials and the choice of material for root canal filling. So this doctor asks that unfortunately she can't find those materials which I showed you in the presentation. The iodent and calcipast, they are not available in her country. So she asked me to choose between the Calacept Plus, the Caliform, and the other one is Ogna iodoform paste. So what I want you to understand is that we don't have to stick to some brand names of the materials, right? We have to know the groups of materials which can be used for root canal obturation in primary dentition. And among those, I want to remind again, are the calcium hydroxide and iodoform paste. And if you choose a material from this group, please pay attention to the vehicle, and it has to be a silicone vehicle, not a water-based, for example, or saline-based vehicle. Another group is zinc oxide eugenol paste, and you can actually add some more antibacterial substances into it, like, for example, iodoform or camphora or some other ones. And another group is zinc oxide plus calcium hydroxide plus iodoform. And the example from this group is Endo. Or it can be the zinc oxide and iodoform group of materials, such as Maisto, Kairai, and some others. So if we look at the contents of those materials which were asked, first of them was Calacept Plus, and Calacept Plus contains calcium hydroxide, barium sulfate, which is the content for radiopacity, and also the vehicle is a sterile isotonic saline solution. So if the vehicle is based on saline or on water, this material will be resorbing very, very fast in the root canals. And this is not a very good option for us, because we are not using it as a temporary one. We are using this material as a material for long-term obturation. So Calicept Plus is not a good choice. Caliform contains calcium hydroxide, it contains iodoform, and also the base is silicone oil. So in my opinion, this material can be used for a long-term obturation in primary dentition. And Ogna iodoformic paste contains iodoform, parachlorophenol, menthol, and some other contents. Okay, so this material, I think, can be used instead of, for example, iodent, which I showed you, which I'm adding to zinc oxide eugenol paste in some cases. So this is how we actually choose the material. We don't pay attention to the brand name, but we pay attention to the group of the materials and the contents of the material. And then we can make our own choice, because of course in every country there are different materials which are available or not available. Another question is, what is the protocol followed regarding continuous bleeding canals in pulpectomy, even with irrigation of sodium hypochlorite? So if, for example, you are instrumenting the root canal and you know that you got through all the working length and there is no pathological resorption and there is still some bleeding, what can be actually a reason for that? The reason can be an open apex, because it can be the stage of root growth, or the reason can be some physiological or actually pathological root resorption. Also, the reason of this bleeding can be some remnants of the pulp in the canal, and also the reason can be the over-instrumentation of the apical foramen. So, depending on the reason, you will choose the way how to deal with it, with this bleeding, right? So, if you feel that you could leave some remnants of the pulp, and how do you feel it? How do you know? If you didn't, for example, use the apex locator, there was no chance to use apex locator, and you couldn't go through all the working lengths, and you couldn't define the working lengths in the right way, then we can actually think about some remnants of the pulp. So in such case, I would try to use a smaller file and try to go a little bit deeper and finish my instrumentation and see if the bleeding is still remaining or not. If you are sure that you are done with your instrumentation and you're sure there are no remnants of the pulp in the apical region, then I would do like this. I would take the endo aspirator and I would just suck all the blood out of the root canal and immediately fill it with the obturation material. And after that, I will take a small cotton pallet and pack the material a little bit in the orifices. So one by one, I will fill the canals like this. And the bleeding is not the contraindication for permanent obturation. Okay, so in primary teeth, it is okay to try to suck all the blood out and put the material inside. And in such cases, probably I would prefer to go for the calcium iodoform pastes, and I would try to use stainless steel or zirconia crown as a permanent restoration, because in such cases I would try to rely on the good sealing restoration a lot, because the good sealing restoration will provide us a good long-term success. So this is how I will actually deal with the bleeding in the root canal, even if it's not stopped after we use sodium hypochlorite solution. Next question was about my opinion regarding broken files in the primary tooth. So if, for example, something like this happened, what you can do, you can, of course, try to use the ultrasound and try to remove this piece of file. Of course, everything will depend on the level of patient's cooperation, on the way how you treat those canals, if you have some magnification, if you have the ultrasound device in your clinic. But if you see that it's not possible to take it out, of course, we need to tell this to parents that something like this happened. They have to be aware of that. And actually, if the the permanent tooth germ is far away, I would probably leave that primary tooth and I would observe, I would monitor it, and we will make some x-rays in the future. And if I see that the root canal and that the root starts to resorb and is getting close to that piece of instrument which was broken, then I will go for extraction. So maybe it would be not an immediate extraction, it would be postponed, but we will have to monitor this tooth to take some x-rays and see the right time when extraction is needed. So this would be the tactics towards such situations. Okay, so now the question is, what is more successful in your opinion, direct pulp capping or partial pulpotomy in primary molars and incisors? What would you prefer? Honestly, I would prefer the partial pulpotomy, and I will explain why. Because I'm using MTA. So for me, it's easier to pack MTA if I did some partial pulpotomy, because then I will have some space in the tooth where I can put the material. If I was using, for example, bioceramics, then it has a putty consistency, and actually it's easier to place it over the exposed pulp, and it's not really needed to make some partial pulpotomy for packing this material. So as long as I work with the MTA, for me, it's just more handy to use the partial pulpotomy technique. As to the evidence and the effectiveness of both procedures, actually, if you use the novel materials, if you don't use the calcium hydroxide, which is actually mentioned in a lot of studies, and calcium hydroxide doesn't work very well for direct pulp capping and also for the partial pulpotomy technique. So if you don't use calcium hydroxide, but instead you are using the calcium silicate cements, such as MTA, such as biodentin, such as bioceramics, so if you use materials from that group, actually the evidence says that the techniques, both techniques, the partial pulpotomy and also the direct pulp capping technique, are both effective. And what is important is also to follow the protocol. So you have to use local anesthesia, isolation, to provide the sterile working field as much as possible in both situations. And of course, we need to take care of a good sealing restoration, because it will have a big influence on the success rate of this method. So to conclude, I would prefer to go for partial pulpotomy, but not because it is more predictable or it's more effective, but because I'm using MTA, which is easier to pack, okay? Honestly, nowadays, I prefer to go for indirect pulp treatment instead of going further and dig further and try to open the pulp and you know, just have this exposure. So I hope I answered your question. Thank you very much. One more. In case of indirect pulp capping, do you clean the cavity with chlorhexidine or sodium hypochlorite before putting MTA? And how thick should the MTA sealing should be? Okay, so if we are speaking about the indirect pulp capping, I would like to divide permanent teeth and primary teeth, because I will use different techniques in both situations. So if I'm working with primary dentition, most of the time I don't use MTA at all. I just put some adhesive, and this is actually a liner, right? And then I put composite. And this filling is also considered to be an indirect pulp treatment, because we clean the walls of the cavity. Maybe we do the selective caries removal, or sometimes we go for non-selective caries removal. It actually depends on the clinical situation. But in both ways, I would not put any MTA on the bottom. I would go straight and follow the excavation with just restorative technique. So I will put adhesive and put composite, okay? And if you're asking about the antibacterial agent which I'm using, I prefer to use 2% chlorhexidine solution to clean the cavity before I go for restoration. And if I'm working, for example, with an immature permanent tooth and I go for indirect pulp treatment technique and I leave a lot of soft dentin in the bottom, okay, so I go for a selective caries removal technique. In those cases, I prefer to put MTA in the bottom. And again, before that, I use some 2% chlorhexidine solution. And I put MTA, and the thickness of MTA will be not more than 1 millimeter. So this is how it goes. And I finish this treatment also with some composite restorations, or sometimes in, for example, molar incisor hypermineralized teeth, I could go with a crown. Next question is, hello, doctor, what did you use for irrigation system in pulpectomy procedure? Thank you. Okay, so probably you're asking about the irrigation protocol, right? If you're asking about that, so usually I start with a sodium hypochlorite solution, and I prefer to use a 2.5% sodium hypochlorite solution. If you go for recommendations of American Academy of Pediatric Dentistry, in their guidelines, they prefer to use and they recommend to use 1% sodium hypochlorite solution. But the lower concentration we have, the worse antibacterial activity we have. And actually the child is not sitting in the chair for a long time, right? So we need to irrigate fast, and the higher concentration we have, the better it is. Also, the root canal system in primary dentition is like a spider web. So there are a lot of anastomosis between the main root canals. And in my opinion, again, the higher concentration of sodium hypochlorite we have, the better irrigation we provide. But if we take a 25% sodium hypochlorite, and for example, we don't notice any pathological or physiological root resorption, or we accidentally make an over-instrumentation of the apical foramen, and by accident you extrude the 525% sodium hypochlorite in the surrounding tissues, in the periodontal tissues, the complications could be worse if you compare it to the lower concentrations. So I prefer to use 2.5% sodium hypochlorite. And I start with that, and I make my instrumentation, and simultaneously I irrigate with a 2.5% sodium hypochlorite solution. After I finish my instrumentation, I go with water, I irrigate with water, or it can be either distilled water or saline. After that, I use my endo aspirator, I aspirate everything from the canal, and I proceed with EDTA. I use EDTA around 1 minute in each canal, but of course it will also depend on the level of cooperativeness of our patient. But we try to use it during 1 minute in each canal in order to remove the smear layer from the walls and open the dentin tubules. After that, you use water again, you irrigate with water, you aspirate it, and I finish with sodium hypochlorite. If I know that there is some level of root resorption, either pathological or physiological, I would go with 2% chlorhexidine solution instead of using sodium hypochlorite. Or if, for example, there is some reason when we cannot use rubber dam for a patient, usually it's because of the cooperativeness of the child, In those cases, I would also go with the chlorhexidine solution, because if the child swallows some sodium hypochlorite, the child will be probably vomiting after that. So it's not very good idea to use sodium hypochlorite without having any rubber dam on. So this is actually the choice of irrigating solutions and the protocol for irrigation. Another question, if I use any sonic or ultrasonic device for activation, or it's not needed. Well, actually, I don't use it. And the reason is because I want to make my treatment faster. If you want to use it, it's not a mistake, but honestly, we cannot disinfect, unfortunately, we cannot disinfect all the root canal system in primary dentition because of the anastomoses which are present. So our root canal treatment is very reliable on the antiseptic properties of the obturated materials which we are going to use, right? On this, on the antibacterial properties of the sealers. This is first. And second, the success rate of endodontic treatment will be very dependent on the good sealing restoration. Honestly, even more dependent than the quality of the root canal instrumentation and the quality of the root canal treatment that you've provided. So that's why I don't use any ultrasound to activate the irrigating solution. But if you have a cooperative child, if you have time for that, you can of course use it. It's not a mistake, right? It will be even better. But again, keep in mind that it will not kill all the bacteria, unfortunately. So we still have to use those materials which have high antibacterial properties and which will be working even after the treatment is finished. Okay, so I hope that I answered all the questions for those doctors who are present today. And for those who couldn't join us and who didn't send me the questions before, you can always contact me in the social media. And of course, I'm in touch and I'm glad to answer your questions. If you have some difficulties or if you have some problems with some cases, you can always write me and I will try to help you. So I would like to thank you one more time for joining this course. I hope it was interesting and I wish you all the best. I wish you to enjoy your work. I wish you to enjoy what you are doing and don't be afraid to make some mistakes, because all of us start with something. And I think the main thing is to love what you do, because when you love what you do, you are a happy person and you are really succeeding in what you do. So thank you one more time, and I hope to see you in our future events, during our future lectures and courses. Thank you so much, and goodbye.